Good morning. My name is Rupal Mansukhani, and my colleague Stacy Hardeo, who also worked on this presentation, is in the back of the room. And we're clinical assistant professors at Rutgers University Ernest Meyer School of Pharmacy. And as part of our assignment, we have three responsibilities. So we have responsibilities to teach at the university. We have outreach, where we do service in the community. And then our third is our research scholarly, which usually occurs at a clinical practice site. And so our clinical practice site is Morristown Medical Center, where we do our clinical research. Our Morristown Medical Center is a hospital in the United States in New Jersey, and you can see the picture right here. It's a teaching hospital, and we fall under an Atlantic Health System. And so we have 4 hospitals that work together, that work independently, but fall under one big system. And our hospital, Morristown Medical Center, is 656-bed hospital, and we primarily see patients that are there for general medicine or surgery. Approximately 34,000 admissions per year we see, and we see about 83,000 emergency room visits. And we're nationally ranked for 4 specialties: geriatrics, cardiology, orthopedics, and pulmonology. And our hospital also has 11 clinical pharmacists, and our clinical pharmacists round within various units. So we have a pharmacist in cardiology, we have one who looks at infectious disease, one that works in the intensive care unit, and so on. So we don't have a pharmacist on every floor for every patient clinically, but we do get a lot of the major specialties covered. So just to give you a little bit of background on our program, we, in 2012, Medicare, which is our national health care plan for our elderly patients, decided to start penalizing hospitals for high 30-day readmission rates. And I spoke to some of you, and I know that may be true in some of your countries as well. And basically what they did was they came out with specific indications, and if a patient was readmitted within 30 days for these certain indications, then the hospital would be penalized and not paid for the previous visit that the patient made. And so currently the indications include a patient that has pneumonia, heart failure, myocardial infarction, COPD, and then total and knee and hip replacement. So COPD, which is the focus of my presentation, really imposes a big burden on our system, and it costs about $49.9 billion per year in indirect healthcare costs. And Medicare in 2003 to 2004 displayed a 30-day readmission rate of about 22.6%. And so these patients that were being readmitted more often were kind of looked at as either they weren't cared for correctly, or their medications weren't correct, or there wasn't enough done for them that they were actually coming back to the hospital. And the exacerbations of readmissions are part of the high medical costs associated with our readmission rates. And so the federal government decided that patients that were readmitted within 30 days that had COPD, the hospital would lose the money for the previous visit. And so just a little bit of background of the guidelines that we currently use for treatment. The Global Strategy for Diagnosis, Management, and Prevention of COPD classifies patients into different categories based on how your symptoms are. And so up here you can kind of see that patients that are category A or B usually have no hospital admissions, and then patients that have at least one hospital admission fall into category C or D. So most of the patients that we're seeing at Morristown Medical Center for COPD fall into this category of C or D. And you decipher between C and D based on 2 tests that you can kind of do. So there's the MMRC or the CAT test, the CAT. And primarily we use the CAT test, and the CAT test asks patients various questions about their daily life and how they feel and how their breathing is based on that. And so based on whatever category they fall into, C or D, the guidelines have a recommendation of what the preferential treatment is for those patients. And so you can see over here for category C and D, the medications that patients should be on are inhaled corticosteroids with a long-acting beta agonist or a long-acting muscarinic antagonist. And so based on this, we kind of started thinking about, how we as pharmacists could make a difference, because we were noticing that a lot of the patients that were admitted to the hospital weren't necessarily on these correct medications. And so the physicians weren't treating to the maximum that they could. And so we decided to kind of look at some data last year to kind of evaluate how effective the physicians were. And what we found were that the rates of the medications being appropriate were very low, and that we were seeing readmissions coming back for patients that have COPD. And so what we decided to do was to kind of do a pilot study to see if the pharmacist were to go and see the patient and come up with various interventions that I'll talk about in a few minutes. Can we examine the correlation of them being on the appropriate medication therapy that I mentioned in the graph? And could we correlate that to 30-day readmissions to see a reduction in readmission rates? And so what we did was we evaluated patients at when they came into the hospital. So before we did any kind of intervention, what their pre-admission medications looked like. And then we looked at their exacerbation medications, so their medications while they were in the hospital. And then finally at discharge, making sure that when they left the hospital, they were put on the correct regimen to prevent them from coming back. And then the secondary outcome that we want to look at is looking at the correlation of drug therapy to their length of stay. How long are they staying on average in the hospital? So the time period that we did our interventions was from January to March of this year, 2015. And data was collected using ChartMax and AccessOne, which is our data collection systems within the hospital. And patient selections were generated using UHC. And the patients that we included were patients that were admitted to Morristown Medical Center. So we didn't look at all the Atlantic Health hospitals. We just looked at Morristown, where we were doing the interventions. And we looked at patients that had COPD, and they could have major complications or comorbidities, or they could not. We also realized when we were looking at just COPD that we weren't able to pull up every single patient that we had seen. And so we added in a couple of other indications that they might have been labeled as while they were in the hospital. So they might have fallen into chronic bronchitis or chronic asthma. And if they did fall into that category, we evaluated them further to make sure that they did indeed have COPD before we put them into the study. Patients that we excluded were patients that were on chemotherapy, that had hospice, radiation therapy. They were going to rehab where they were not going home. If they had a death during the admission, delivery or birth, or a mental disease or alcohol and drug use. So these patients were not included in our study. And these patients were also not seen by the pharmacy group. So the collection of data that we thought was beneficial for this included patients' age, gender, race. We looked at their comorbid conditions because that could affect the readmission rate, previous admissions, readmissions, and then we looked at their treatment right when they came into the hospital, during admission and at discharge. And so patients were divided into two groups. And so because of our faculty status at Rutgers, we typically spend about 4 days a week in the hospital and 1 day a week at the university. And that varies. If we have a week of high teaching, we may not be at the hospital as often. So we weren't able to see every patient that had COPD. And so what we did was we divided them into two groups. The patients that we saw while we were in the hospital, where the pharmacist actually went, or the pharmacy students actually went and educated the patient, they fell into the pharmacy group. And any patient that we did not see automatically fell into the non-pharmacy group. And so typically, our typical day as pharmacists, we have 2 to 3 pharmacy students with us regularly, and we are part of a multidisciplinary team. So that includes a physician, a nurse. It can also include care managers, social workers, respiratory therapists, medical residents, and medical students. And it just depends on which floor unit you're on to identify how big your actual group is. And so, all the patients that the pharmacist actually evaluated or changed drug therapy fell into pharmacy group. Everybody else fell into non-pharmacy group. So the actual interventions that I made and Stacy made were doing COPD education. So we educated patients on their actual disease state and what it meant for them. We looked to make sure that their home meds were appropriate. Their exacerbation meds while they were in the hospital, we made sure that they were correctly dosed, and then we made sure that the discharge medications were appropriate. We made sure that their vaccination history was up to date and that they didn't need any additional vaccinations while they were there. We converted patients from IV medications to oral medications as soon as we could to kind of hopefully decrease their length of stay. And then we also looked at assessment of device techniques. So we would go, if a patient was on a discus inhaler, we would actually go with a discus placebo inhaler and give it to the patient and ask them to demonstrate how they used it to make sure that they're using it appropriately. And then we also looked at medication and device access. And a lot of these medications for COPD in the US are very expensive. And so if the patients don't have insurance, it could be around $200 to $300 per prescription. And so a lot of these patients, if they're feeling okay, they won't take their medications because they feel that it's okay for them because they feel okay. And so what we did was we applied for a grant through the hospital and received a grant. And so patients that had financial difficulties, we actually gave them a 1-month supply of medication for free, while the social worker in the hospital worked with them to make sure that they had insurance on the outpatient side to ensure that the following month they could get their medications. And then finally, if they were smoking, smoking is a big risk factor for COPD. So if they were smoking, we referred them to our smoking cessation person in the hospital so that they could try to quit smoking. And so the statistical analysis that we used was the chi-square test to look at appropriateness of medications and the 30-day readmission rates. And then we used the Mann-Whitney U test to look at the relationship for length of stay. And so this is our data. And so our average, and you can see that we broke them up into pharmacy and non-pharmacy. And so the average age that we see for patients that have COPD typically is 74 for the pharmacy group and 75 for the non-pharmacy group. If the pharmacy group had a higher number of males, whereas the non-pharmacy group had a higher number of females. And then Morristown Medical Center, where we're located, primarily has a Caucasian population. And so 90% of our patients in both groups were Caucasian, and you could see the race breakdown for everybody else on the slide. And so there was no statistical difference between the two groups, and so they were pretty similar. So we recruited in our 3-month time frame 468 patients, and 255 of them fell into the pharmacy intervention group, and 213 fell into the non-pharmacy group. And so when you look at appropriateness of medications, you can see the pre-admission, which really pre-admission was not affected at all by pharmacy because those were the medications that the patients were taking before they came to see us. And so we couldn't really intervene on those. And so the pre-admission rates, you can see pharmacy's group was 23% and the non-pharmacy group was about 19%. And so we just kind of wanted to get a baseline data to kind of see how are they doing before they even come to the pharmacy for their appropriateness of medications. And so now when you look at exacerbations, so this is while they're in the hospital, you can see that the pharmacy group had a higher rate to get patients on the appropriate medications. And so we had about 52% compared to the non-pharmacy group, which had about 30%. And the discharge medication, and this was statistically significant with a p-value of less than 0.001. And for the discharge meds, when the patients were leaving the hospital, you can see that pharmacy group was 69%, whereas the non-pharmacy group was 24%. And with the exacerbation meds, I think we had a lower number than the discharge meds because a lot of the physicians like to, they have their own ways of treating. And so even though the guidelines recommend that they should be on certain medications, the physician may or may not be receptive to our intervention. And unfortunately, we didn't track how many of our interventions were accepted, but moving forward, we will be tracking to see, if we make a recommendation for appropriateness for exacerbation meds, was it actually changed to the appropriate med, or did the physician deny our recommendation? But both groups did show that the pharmacist did make a significant difference with getting patients to the appropriate medications. And then readmissions, which is the whole reason we did this pilot, we looked at readmissions within 30 days, and we found that patients that were readmitted in the non-pharmacy group were about 30% of them were readmitted within 30 days, whereas in the pharmacy group, only 13% of them were readmitted. And sometimes readmissions, you can't prevent them because if they're later stages, they're going to be readmitted for various reasons. We also picked the time period from January to March, which is the highest rate of COPD exacerbations. And so we are going to see some readmission rates. Now, if you remember earlier, I mentioned that the national rate was around 26.2%. And so the non-pharmacy group looks like they're kind of above the national rate, and the pharmacy group is definitely lower than the national rate. And so this is statistically significant difference. So we also kind of wanted to take it past 30 days and look at the 60 and 90-day readmission rates. And so we looked at 60-day rates and 90-day rates, and what we actually saw was that the pharmacy group was a little bit higher than the non-pharmacy group, which did kind of surprise us. It was not statistically significant, so there was no difference between the two groups, and you can see the percentage is not too much, but what we hypothesized was did they not get the medications, because many of these patients received free medications for 30 days. So after 30 days, did they not have enough medications? Did they not get their refills? What was the reason? And so we kind of have to do a little bit more research to figure out why we go back at 60 and 90 days. The length of stay was not significant. We saw that it was 6 days for the pharmacy group and 5 days for the non-pharmacy group. And the average length of stay in the United States is about 5 days, so it's typical to what we would expect. So some next steps that we have to do, what I'd like to do is really correlate the drug therapy to the length of stay. So even though on this slide I mentioned that the pharmacy group had 6 days, I kind of want to look at if the patients that were on appropriate therapy, did they have a lower length of stay compared to the other groups? And then also correlating the drug therapy to the readmission. So we definitely saw that the readmission rate in the pharmacy group was lower at 30 days, but does the drug therapy correlate to it? So if the patient is on the correct medications during the hospital and at discharge, does that actually correlate to readmissions? So kind of breaking up and subdividing the data to kind of analyze it. And then, of course, we're continuing this. So even though we only looked at data from January to March, we've still been seeing patients regularly that have COPD. So hopefully, at the end of this year, we'll have a full year of data to kind of increase some of the statistical analysis that we can do. So in conclusion, pharmacists continue to work with the multidisciplinary teams and we try to optimize their exacerbation and discharge medications. Pharmacists can be utilized in a team approach, and we, as pharmacists, pharmacy technicians, students, and residents have a beneficial role in medication reconciliation and discharge education and preventing patients that are high risk from being readmitted. I'd also like to acknowledge a few people. So Stephanie was the person who did some of the statistical analysis for us. And then Melissa and Stefan are both students at Rutgers University, and they helped us do some of the data collection. So with that, I'll take any questions you may have. Do I have time for questions?
Do you have any questions? Okay.
Hi. I have a question. Did you try to optimize the administration? I mean, the therapeutic, the therapeutic design. No, when, for instance, when they use more than one medicament, just to try to optimize.
When they're trying to use more than one medication?
I mean, because, you know, in Germany, some of the doctors, they are, the pharmacists, they are at this moment trying to work together with the doctors in order to optimize the medication, in order to better range this correlation between the therapy and the time that they are in the hospital. And this is very interesting work. I mean, this is one of the important things if you really want to have this correlation, to optimize.
Yeah, so we did, the purpose of us seeing the patients was to optimize their medication. We didn't do it just for COPD. We actually looked at all their medications. So we made sure that you know, their heart failure, if they had COPD and heart failure, we looked at all the medications to optimize them. And we tried to do this during the hospital stay and right before they were discharged.
I have to tell you that I like a lot this frame that you prepare with the symptoms and with the categories and with the diagnostic, and really I take it a look.
Oh, thank you.
I wrote down. Okay, thank you.
Yeah, I mean, if you'd like a copy of it, I can always send it to you. We can talk after.
Yes.
Okay?
Okay, thank you.
Any other?
Just have small questions. Are these patients subjected for biochemical screening? Screening, for blood screening or blood tests?
So are you asking about how we screen patients?
Yes.
Okay, so any patient that was admitted to the hospital that had COPD, they automatically either fell into our group or the other group, as long as they didn't have an exclusion. So we didn't have a screening. The only thing we did the screening for was the grant. So if we gave them 30 days of free medications, we did ask them 6 questions that asked about, you know, if they were likely to take their medications, you know, did they have trouble paying for it? So we screened for that. So not every patient got free medications, just the ones that screened in the right direction.
Okay, thank you for your presentation.
Okay, thank you.
And this is your certificate from the conference.
Oh, okay.
Okay.